Hey guys, welcome back to my channel, The ENT Resident. Today we are going to talk about a very common acute laryngeal infection that is very commonly asked in your vivas, your theory exams, and this disease is known as croup. And it has another name to it. It's also known as acute laryngotracheobronchitis. And this is very closely compared to acute epiglottitis a lot of the times. In my previous class, I've spoken about acute epiglottitis. Today, we are going to talk about croup. You can also now purchase my notes. I've added links in the description. Okay, so let's get started. So, we are going to first start with what is croup or what is acute laryngotracheobronchitis. Now, as the name itself is suggesting, it is an acute inflammatory condition which is involving the larynx, the trachea, as well as the bronchi. So these three regions are getting involved in an acute inflammatory condition. This condition has also been termed as croup, and this is a common name that we very commonly identify with. And croup has actually seemed to be way more common than the incidence of acute epiglottitis. And viral croup, now croup can be viral or bacterial. Now the one that we usually talk about is the viral component. There's another bacterial one, which is also known as pseudomembranous croup. We'll also talk about that at the end of this video. So, viral croup is actually the most common cause of airway obstruction in children. And this is a very important MCQ question that you need to remember. Next, coming to age group, again, another MCQ question over here. What is the age group that this affects usually at? The common age group is about 6 months to 3 years of age, whereas the peak incidence is seen in about 2-year-old children. If you remember acute epiglottitis, the age group was actually quite different. It was 2 to 8 years. Now we'll talk about all the differences between croup and acute epiglottitis in a separate video where I'm going to talk only about the differences. But for today, let's just know that. So the age group is actually quite young, 6 months to 3 years of age. And here you'll see actually a male preponderance more than females. And there's an annual incidence of 1.5 to 6 percentage. And it is more common during the time of winters. So these are some basic information that you need to know about acute laryngotracheobronchitis. Now coming to what is the cause behind it. Now classically the virus that has been associated with it is the parainfluenza virus type 1. This is a important MCQ question again. But there are other causes as well, like parainfluenza virus type 2, respiratory syncytial virus types A and B, rhinovirus, metapneumovirus, coronavirus, Boca virus. And sometimes this is a viral disease, but there can be a secondary bacterial infection later, and that can be caused by Streptococcus pyogenes, Staphylococcus, hemolytic streptococci, and Haemophilus influenzae. So this is about the etiology of croup. Now we are going to talk about pathogenesis of this particular disease. Now this is a very important one. Again, this is also very commonly asked in your theory exams. So when the person gets a viral infection, what happens? There is submucosal edema developing. Now, because of this involving the larynx, trachea, as well as the bronchi, first we see a mechanical obstruction of the subglottic region. We'll talk about why subglottic area is very crucial over here and why this is more commonly affected in a little bit. And there is also mechanical and secretional obstruction. There's a lot of secretions forming up, so which ends up blocking the tracheobronchial tree as well. So we are having a mechanical obstruction both at subglottic level as well as the tracheobronchial tree. Now, because of the subglottic block, we are seeing inspiratory stridor in our patient, and because of the tracheobronchial tree block, we are seeing a prolonged inspiratory phase with a wheeze. Now, all of this combined, what the child undergoes is they end up in hypoxia and they become very restless. Now, because of hypoxia, that leads to cyanosis as well as hypercapnia and acidosis. All of these together will lead to a stuporous, quiet, glazed facial expression, and this will eventually lead to a reduction in the air entry into the chest and a reduced cough reflex of the patient. And if all of this persists, it can actually lead to respiratory failure, even. So, I have hope you have understood how the disease is progressing and what is the pathogenesis behind it. It started all with the viral infection leading to submucosal edema and a mechanical and secretional obstruction at these two levels, development of stridor and wheeze leading to hypoxia, restlessness, cyanosis, hypercapnia, and eventually leading to what are the typical features that we see in our patient. So that's about our pathogenesis. Next, we are going to talk about what is the pathological changes that we are going to see in this case. So we'll see that the primary area that is involved here is the subglottis actually. We'll be seeing a swelling of the loose areolar tissue in this particular region, and this is the reason why the patient will have airway obstruction as well as stridor. And the type of stridor that we are seeing over here is inspiratory stridor. And we'll also see that there's a lot of thick, tenacious secretions and crusts which are obstructing the airway. Now, coming to the question, very important Viva question, that is, why is the subglottic area very crucial over here? So, if you remember the age group is 6 months to 3 years of age, right? So, if you remember the anatomy of larynx, you can check out my videos where I describe more in details. So, in the anatomy of larynx, if you remember the cartilages, cricoid cartilage is one of the cartilages. Now, this is the only cartilage or the only area in the upper respiratory tract which has a complete cartilaginous ring. All of the others, they are not a complete cartilaginous ring. So, because of this, what happens because it is a complete ring, it prevents an outward extension of the edema which develops in the region. And also, the lining epithelium in this subglottic region is actually quite delicate, and the submucosa is made of very loose areolar tissue that easily allows edema to develop. So, these are some important anatomical features that you need to know. Now, another important for the particularly the pediatric airway is that subglottis is actually the narrowest portion of the pediatric airway. Now, this is very, very important. I have a separate video where I have discussed about the differences between adult and a pediatric larynx. You can check it out over there. This is a very crucial piece of information here because the subglottis is the narrowest portion of the pediatric airway, along with the fact that this is a complete cartilaginous ring, so the edema cannot extend outwards, and the lining epithelium is very delicate. All of these reasons are the reasons why the subglottic area gets narrowed in this particular disease. Next, we are going to talk about the clinical features of this disease. So, every time we talk about clinical features, we divide it into symptoms and sign. Symptoms are what the patients come to you with, and signs are what you see when you examine the patient. So, the symptoms that we'll be seeing, it is happening primarily because of the mucosal edema occurring in the larynx and trachea following the viral illness. So, a typical symptom would be you will get a preceding history of an upper respiratory tract infection, meaning the patient child will have initial history of a low grade fever, cold, cough, and malaise. Following that, certain features will develop which are very important to remember. First of all, is one of the key symptoms is hoarseness of voice. Second is their cough. The character of the cough, it will be a brassy and a barking, croupy cough. This is also known as the seal's bark. This is the particular characteristic of the cough that you will see in your cases. Then the patient will have difficulty in breathing, throat pain, and a very important differentiating feature over here with acute epiglottitis is that there will be absence of drooling of saliva in these cases. So these are the symptoms that our patients with croup will come to us with. Now, what are some factors which are predisposing to even severe symptoms? One is that if there is any pre-existing subglottic or tracheal narrowing, if there is a case of subglottic stenosis already pre-existing in your patient, a case of chronic lung disease, or if the patient has airway reactivity, which is characterized by a history of inhalant or food allergies. So, these are all things that will make the disease in your particular patient much more severe. The symptoms will be much more severe. So, we start with the preceding history of an upper respiratory tract, like a common viral, where you have low grade fever, cough, cold, malaise. Then the patient develops hoarseness of voice, this typical seals bark like cough, difficulty in breathing, throat pain, and absence of drooling. So, these are all the features that we need to remember here. Next, talking about the signs. So, when you examine the patient, the child will be restless and anxious. Usually, the patient will not be toxic. Now, this is again a feature that differentiates with acute epiglottitis. Acute epiglottitis children they'll have a very toxic look. They'll have high grade fever, tachycardia, tachypnea. Those are all things that will make the child look very toxic. Then patient may or may not be febrile over here. And the stridor that you see over here is an inspiratory or a biphasic stridor. And in very severe cases, you will be seeing some respiratory failure signs like flaring of the nasal ala, suprasternal retraction, and intercostal retraction. So these are our clinical features that we'll be noticing in our patient. Now, if the patient is not treated on time, it can actually lead to some complications developing in them, which is, we just discussed, respiratory failure, as a result of which metabolic acidosis and respiratory acidosis. Next, we discuss about how do we classify the severity of our patient. Now, there is a common score used over here, which is the Westley Croup score. Now, this is a scoring system which is based on 5 clinical features that we see in Croup, which is inspiratory stridor, retraction, air entry, cyanosis, and loss of consciousness. So, we are going to score each 5 of these features that we see in Croup. So, the total score, what we end up getting, will be correlating with the diameter of the tracheal lumen. So, a maximum score of 17 can be achieved here. And how do we classify it? A mild Croup will have a score of 2 to 3, moderate Croup will have a score of 4 to 7, and severe Croup will have a score of 8 or more. Now, let's look at the scoring system over here. So, the first clinical feature is inspiratory stridor. So, we'll give a scoring of 0 to about 5. So, when there is no inspiratory stridor, we give a score of 0, 1 for audible inspiratory stridor with a stethoscope, 2 for an audible without a stethoscope. Then 3, 4, 5, we do not have any ratings here. Next feature is retraction. If there is no retraction, it's 0, 1 for mild, 2 for moderate, and 3 for severe. Then we check for air entry. If it is normal, this is 0. Decreased air entry gets 1. Severely decreased gets 2. Then we look at cyanosis. If there is no cyanosis, we score it as 0. If there is cyanosis with agitation, we score it as 4. And at rest, we score it as 5. And then last of all, we look at the consciousness level. Normal gets a 0 point. And if that is altered, then it gets a 5 point. Now, from based on what the scoring is, you'll calculate the total score, and then we will classify them as mild, moderate, or severe. And this will correspond to the or correlate to the diameter of the tracheal lumen. So that's about our Westley Croup score. Next, how are we going to investigate our disease? So, diagnosis of croup is actually quite a clinical diagnosis. We do not need to do investigations at all. Just from the history and the clinical features itself, we are going to be making our diagnosis. But in very severe cases, in case you are having a diagnostic dilemma, we can use some radiological investigations. So, again, a very important question coming up over here, which is a MCQ question. When we do a X-ray of the thoracic inlet or the neck and an anteroposterior view, we are going to see a particular narrowing of the subglottis, because that is the main pathology that we are seeing here. Now, because the subglottis gets narrowed, this produces this typical feature that you're seeing here. It looks like as if it's looking like a pencil tip, right? If you look at this looks like a pencil tip, or it even looks like the steeple of a church, which is this image over here. So that is why this sign has been known as the steeple sign or the pencil tip sign. Now, can you tell me which are the signs that we see in acute epiglottitis patient? So, in case of X-ray neck, which in there you do a lateral view, you will be seeing thumb sign. And another sign that is commonly seen, which is not a radiological sign, it's just a clinical sign you see. This is the tripod sign in epiglottitis. I have a separate video where I talk about the different signs in epiglottitis and croup. You can check it out over there. So this is about a radiology here. Next, we can even perform a flexible fiber optic laryngoscopy. However, we should perform it only in the OT and ready for intubation in case necessary. It will only reveal subglottic edema and supraglottis will typically be normal. Then we can even do an X-ray of the chest if you want to rule out some chest diseases like basal collapse, mediastinal shift, pneumonic patch, emphysema, presence of foreign body, pulmonary edema, all of these things. And lastly, HRCT of the neck and mediastinum. This is something that is indicated only in cases of recurrent croup. And only this will help you in ruling out other differential diagnoses, like maybe the patient has subglottic stenosis, which is why they are not getting better, or they are contracting the disease multiple times, or maybe there is a presence of a foreign body. These are things that you can find out via this. So this is all about the investigations that you need to do for croup. Now let's talk about treating the disease. How are we going to treat it? The good thing over here to know is that this disease is actually very self-limiting. About 50% children are seen to improve within the 24 hours of onset of their symptoms, and most of them recover within 4 days even without treatment. But in rare cases, the airway symptoms can become very serious as well as life threatening. But mostly for the mild cases, supportive treatment is all you need, with mainly reassurance of both the caregiver of the child as well as the child. And you monitor and observe the symptoms of the child, how it's progressing. So, most of the cases will require a very supportive treatment, whereas only rarely severe cases will require much more than that. So, what is the treatment protocol over here? First of all is hospitalization. So, patient needs to be kept under observation to check whether their symptoms are worsening or their difficulty in breathing is getting worse, if there's an impending airway obstruction coming up. Second, we'll start the patient on oxygen with about 3 to 5 liter per minute flow rate. Then humidification of the inspired air. This will what it will help. We have spoken about in the pathology how there's a lot of secretions and crusts developing in the tracheal region, and these tenacious secretions can actually help in blocking up the tree, which is leading to the airway obstruction. So humidification will actually help in softening up these secretions and crusts. Next, we are going to give IV fluids to combat the dehydration that comes on as a result of the viral. Next, the mainstay of treatment for croup, the main medical treatment that we give here is using corticosteroids. Now, what is the mechanism by which steroids are working over here? So, steroids have a systemic anti-inflammatory effect. Second, what it does is it reduces the capillary endothelial permeability, because of which there is a reduction in the mucosal edema happening. We read in pathology that the primary reason why all of the symptoms are happening is because of the edema developing in the mucosa and submucosa. So steroids are going to help in reduction of that. Next, it also stabilizes the lysosomal membranes and therefore reducing the inflammatory reaction in a patient. And they also have a very local alpha mediated vasoconstriction effect. So these are the mechanisms by which corticosteroid is going to help. Next, looking at what are the steroids that we are going to be using. Most commonly, we use oral or IV dexamethasone at a dose of 0.6 milligram per kilogram of body weight. Here, I'm mentioning oral or IV because intramuscular injections are to be avoided because they have a potential for causing muscle necrosis in your patient. Second, we have nebulized budesonide. 2 milligram of that is given. This is usually given in a child who is vomiting. And thirdly, we can even use IV hydrocortisone 100 mg. Now, the clinical benefit that you see after administering the medication, you can easily calculate it by seeing an improvement of the Westley Croup score that we just discussed above. So this was corticosteroids. Next, we have another thing to give, another medical treatment, which is nebulized epinephrine. Now, what is the dosage here? This is important to know. 1 ml of 1 in 1000 epinephrine diluted in about 3 ml of 0.9% saline. And this is given via either a nebulizer or an intermittent positive pressure breathing. Usually, we give 3 doses at a gap of 30 minutes, followed by SOS requirement. Now, how is nebulized epinephrine working and helping these cases? So, we are going to target the primary pathology that we studied, which is mucosal edema developing. So, we are going to reduce the mucosal edema by the alpha agonistic effect, therefore causing vasoconstriction and bronchodilation. A maximum effect is achieved within 30 to 60 minutes of administration of the nebulized epinephrine. But however, this is actually a very short symptomatic relief. It does not give any lasting effect beyond about 2 hours. And also, it does not alter the natural course of the disease that it's going to take. It is probably only going to postpone or eliminate the need for any airway. Airway interference, like needing an artificial airway, like intubating the patient or a tracheostomy. It'll only give some symptomatic relief until you can end up giving the effective treatment. So this nebulized epinephrine, we usually give it at the same time as the glucocorticoids. So these are our two medical management over here. Next is heliox. Now, what is heliox? Heliox is actually a mixture of helium and oxygen, and generally the ratio of helium and oxygen is either 70:30 or 79:21. Now, why is this working? Let's understand the mechanics behind it. So, helium is actually less dense than air or oxygen, and it is more viscous. As a result of which, it is more likely to produce a laminar and more efficient flow in the presence of a partially obstructed airway in comparison to air or oxygen. So, therefore, we give inhaled heliox delivered through a high flow system, and this how it is going to help? It is going to help reduce the work of the breathing of the patient, and it will result in larger tidal volumes and improved gas exchange. Now, the disadvantage of using heliox is that it has very high thermal conductivity, so you have to take care by using humidification along with it in order to avoid hypothermia in your patient. So this is about heliox. Next, if there is a secondary bacterial infection, we even give broad spectrum antibiotics to treat those infections. And lastly, there is intubation and tracheostomy. This is only in very rare cases of airway obstruction. The indications of intubation is if there is rising CO2 levels in your patient, or there is a worsening neurological status, or there is a decreasing respiratory rate in your patient. These are the cases where we are going to consider intubation in our specific patient. When do you think that the patient is ready for extubation in case you have indeed intubated your patient? If they have no fever and the secretions have reduced. Tracheostomy is again a very last ditch measure. We prefer tracheostomy only when intubation is expected longer than 72 hours. So that completes our treatment portion about croup. And lastly, we'll talk about what is the differential diagnosis. Say you're having a case of recurrent croup also. There are other differentials that you need to think about. So there can be foreign body in the larynx, epiglottitis, subglottic hemangioma, angioneurotic edema, bacterial tracheitis, diphtheritic croup, retropharyngeal abscess, or even subglottic stenosis. So these are the differentials that you need to keep in mind. Lastly, before I end this class, we are going to talk about the second variant, which is the bacterial laryngotracheobronchitis. So far, we have only spoken about the viral one. The bacterial one is actually much less common. What is it exactly? How do we define it? It is actually a much severe form of laryngotracheobronchitis, which is characterized by the presence of profuse mucopurulent secretions with sloughing of the respiratory epithelium. So you can see how severe it is. There is sloughing of respiratory epithelium happening. It is rare, but it is potentially life life-threatening cause of upper airway obstruction in children. Now, the other names by which we know it as is pseudomembranous croup. This is because of the pseudomembrane which is developing over here. Also known as bacterial tracheitis, membranous laryngotracheobronchitis, or neonatal necrotizing tracheobronchitis. The causes over here, as I mentioned, is bacterial. So the culprits are Staph aureus, Haemophilus influenzae, Moraxella catarrhalis, Pneumococcus, and Pseudomonas aeruginosa. Now let's talk about the clinical features. Here, there is a difference with our viral group over here. This affects more of older children in the age group of 4 to 8 years. Again, it's same more common in boys. Here, the child will be toxic with high fever and they'll have a worsening stridor that will fail to respond to treatment with steroids as well as nebulized epinephrine, which was working for our viral group cases. And secretions are going to be very adherent. It is not effectively cleared out by coughing. It can even end up occluding the airway, causing respiratory compromise. You can see how in this image, it's not very clear, I'm sorry for that. There is a pseudomembrane which has developed in the trachea. So all these sloughing of the respiratory epithelium, the secretions, they all end up forming this pseudomembrane. Now, to diagnose this disease, you actually need a very high level of suspicion for an early diagnosis. So, to confirm the diagnosis, we need to perform an airway endoscopy where we are going to notice the pseudomembrane in the subglottic and the tracheal region, thick mucopus, and debris extending into the bronchi. A direct laryngotracheobronchoscopy under general anesthesia and removal of all tracheal secretions with pulmonary toilet is mandatory, often necessary to secure airway by intubation over here for a couple of days. The mainstay of treatment over here would be to use IV broad spectrum antibiotics, and we have to repeatedly clear the airway. So we have to do a repeated therapeutic tracheobronchoscopy to clear up the secretions. Now, the complications of this is that it can lead to airway stenosis, acute respiratory distress syndrome, respiratory failure, toxic shock syndrome, anoxic encephalopathy, and even death. So, this is the much more severe variant of laryngotracheobronchitis, also known as pseudomembranous croup. That completes our class today. I'll see you in my next class. Thank you.